Good morning, students. Today, we'll be having a class on mucogingival surgery. Hope you all know what mucogingival surgery is all about. The term mucogingival surgery was introduced in 1950s by Friedman and was defined as surgical procedures designed to preserve gingiva, remove aberrant frenum or muscle attachments, and increase the depth of the vestibule. Periodontal plastic surgery is defined as a surgical procedure performed to correct or eliminate anatomic development or developmental or traumatic deformities of the gingiva or alveolar mucosa. Originally, periodontal plastic surgery was referred to as mucogingival surgery. The original concept of mucogingival surgery addressed only three problems: shallow vestibule, the aberrant frenum, and problems associated with attached gingiva. Periodontal plastic surgery, although it includes those areas, encompasses a much broader range of treatment, including crown lengthening, bridge augmentation, grafting, papillary reconstruction, etc. Now, what are the principles of mucogingival surgery? For that, you must know these things. That is, existing keratinized gingiva should always be maintained. Then exposing bone to increase the zone of keratinized gingiva is contraindicated, said by Widman in 1964. When an adequate zone of attached gingiva exists, vestibular depth is not a factor, said by Bonham. Now, objectives are to create an adequate zone of attached keratinized gingiva, to eliminate pockets that extend below mucogingival line, to eliminate muscle and frenum pull, to deepen vestibule, to cover denuded root surfaces for aesthetic reasons or for hypersensitivity, to stabilize and maintain a healthy mucogingival complex, to correct areas of progressive gingival recession. Okay, now what does mucogingival surgery deal with? It deals with problems associated with attached gingiva, problems associated with shallow vestibule, problems associated with aberrant frenum. These are the things with which mucogingival surgery deals. Now, problems which are associated with the attached gingiva. Widening the attached gingiva accomplishes the following four objectives. That is, enhances plaque removal around the gingival margin, improves aesthetic components, reduces inflammation and reduces the inflammation around the restored tooth actually, and gingival margin, it binds around the teeth with the attached gingiva. Now, techniques to increase the attached gingiva. These are the techniques, that is gingival augmentation apical to the area of recession and gingival augmentation coronal to the area of recession. Now, coming to gingival augmentation apical to recession, these techniques include free gingival autografts, free connective tissue autografts, and apically positioned flap. And you must know what free gingival autografts are. It was initially described by John in 1963. The classic technique includes, that is, first step is to prepare the recipient site. The purpose of this step is to prepare a firm connective tissue bed to receive the graft. The recipient site can be prepared by incising the existing mucogingival junction with the number 15 blade to the desired depth. So these are the photos. This is how it has to be done. The periosteum should be left covering the bone. Now, this in the first picture, you can see before treatment, you have minimal keratinized gingiva. You can see the free gingiva very clearly. Second in photo shows you the initial stab incision at the mucogingival junction with the blade held parallel to the bone. Now, the third photo, you can clearly visualize the continuation of incision horizontally and apically. Now, the fourth photo depicts the recipient site prepared for free gingival graft. The second step is to obtain the graft from the donor side. The classic or conventional free gingival graft technique consists of transferring a piece of keratinized gingiva approximately the size of the recipient site. For the classic technique, a partial thickness graft is always used. Now, the palate is the usual site from which the donor tissue is removed. The graft should consist of epithelium and a thin layer of underlying connective tissue. Now, place the template over the donor site. Make a shallow incision around it with a number 15 blade. Insert the blade to the desired thickness at one edge of the graft. Elevate the edge and hold it with the forceps. You can see the photos clearly. That is how you have to do it. Continue to separate the graft with the blade, lifting it generally as separation progresses. Placing sutures at the margins of the graft helps control it during separation and transfer and simplifies placement and suturing to the recipient site. After that, the graft is separated. Then remove the loose tags from the undersurface. Thin the edge to avoid bulbous marginal and interdental contours. Once that is done, proper thickness is important for survival of the graft. It should be thin enough to permit diffusion of the fluid from the recipient side, which is essential in the immediate post-transplant period. A graft that is too thin may necrose and expose the recipient site. You have to be very careful while doing that. If the graft is too thick, the peripheral layer is jeopardized because of the excessive tissue that separates it from the new circulation and nutrients. Thick grafts may also create a deeper wound at the donor site and the possibility of injuring major palatal arteries. The ideal thickness of a graft is between 1 and 1.5 millimeter. Now, this is the picture showing you the graft, the thickness of the graft. Coming to the third step, that is transferring and immobilizing the graft. Remove the sponge from the recipient site, reapply it with pressure if necessary until bleeding is stopped. Remove the excess clot. The thick clot interferes with vascularization of the graft. Position the graft and adapt it firmly to the recipient site. Suture the graft at the lateral borders and to the periosteum to secure it in position. This is the photo which shows it. After suturing, pressure is exerted against the graft for 5 minutes in order to eliminate blood and exudate from the place in between the graft and the recipient. See the first picture, graft is transferred to the recipient side and sutured. This is the second picture, shows the healing after 6 months. Now coming to the fourth step, protect the donor site. Cover the donor site with a periodontal pack for 1 week and repeat if necessary. Retention of the pack on the donor site can be a problem. To retain the dressing in the palatal site, a stent usually has to be used. Now, there are other techniques other than the technique which we discussed earlier, that is the accordion technique. The accordion technique was described by Rakshak in 1985. It attains expansion of the graft by alternate incision in the opposite sides of the graft. This technique increases the donor graft tissue by changing the configuration of the tissue. The second is the strip technique. The strip technique was developed by Han in 1993. It consists of obtaining 2 or 3 strips of gingival donor tissue about 3 to 5 mm wide and long enough to cover the entire length of the recipient site. These strips are placed side by side to form one donor tissue and sutured on the recipient side. The area is then covered with aluminum foil and the surgical dressing is done. And this is the photo in which you can see mucosal tissue around the implants. Now the recipient site is prepared. Now the strips are removed from the palate. These are the strips, and once the strips are removed, it is placed on the recipient side and see the healing after 3 months. So students, for today, we'll wind up with this. Hope you can go home and revise the topics which we have taken today. Thank you.